So I wanted to talk a little bit about Parkinson's disease because it kind of understanding the pathophys is kind of interesting. So I think you have to sort of start off with understanding that the basal ganglia really involves three main structures: the substantia nigra, the stratium, and the thalamus, and they all kind of communicate with each other. And so in Parkinson's disease, we know that the biggest problem seems to be in the substantia nigra, because that's where there's loss of dopamine. So not as much dopamine is actually put in or released that can be used. So what does this basal ganglia, so all these three components, do? Well, they really help in balancing our movement. And all of these three are really important, but I'm going to kind of break it down into a little bit a different kind of thinking about it. So and I'm going to kind of focus a little bit more on the thalamus and the substantia nigra. So think of it in this way. So the thalamus is really the component that keeps us moving. Like, if you want to run or if you want to go somewhere, that thalamus is the thing that keeps us in our ability to sort of move forward and get something done. And this is kind of balanced mainly by the substantia nigra, which tends to kind of keep things in check. Now these three are constantly communicating with each other, and again, it's the big issue tends to be the substantia nigra when we start to lose dopamine. So what happens in Parkinson's? Well, so as I said before, the thalamus is the thing that keeps us going, and it helps us. As I said before, kind of helps us to move forward. So the substantia nigra it basically helps to signal the thalamus to act, to start moving, start running, start doing all these things. So it kind of has a pathway of which which we call the direct pathway, which kinds of turns things up, so makes things go. And so when somebody has Parkinson, and again we're talking about mainly the substantia nigra, then these loss of dopamine, it means that it can't excite the muscles to move more. So if the muscles can't move more, if it can't kind of relay that message to the thalamus to keep going, keep going, keep going, then you're going to start to get a slowness. But it also has the ability to, in a sense, go through another process called an indirect process, which helps to turn down the thalamus. So it kind of has a dual role here. And if you lose the dopamine, then what it tends to also do is to slow the muscles too much. And remember that this is kind of a constant relay that's occurring. And because of the fact that you have this loss of dopamine and the inability to relay message in a nice coordinated fashion, then what can occur is, as we see in Parkinson's, that you start to get these slow movements. You start to get everything kind of slows down, but it becomes rigid and slow. But on the other case, in people who have Parkinson's, you also see tremors. So how do you get these tremors, which are kind of almost like fast movements, but other aspects are relatively slow? Well, that kind of comes back down to the fact that if you don't have dopamine, that means that because in in your neurons, at the base of the neurons where they're being sent into the dendrite, you also have acetylcholine. So if you don't have dopamine and enough acetylcholine to balance kind of each other out, and instead you lose the dopamine, you might have too much acetylcholine, which is also being released. Then you will also get not just the rigidity, but you start to get tremors. If you have too much acetylcholine, you end up getting tremors, and so you will see that people who have Parkinson's disease oftentimes have tremors. So let me kind of just tie this in a final note. So let me just kind of picture this. So you are getting out of your car and it's raining. And so you're like, oh my gosh, I've got to get into the building. So what do you want to do? You want to run. So it's kind of that relay between the substantia nigra, also involving the stratium, but telling the thalamus to run, hurry up, hurry up, hurry up. And so that getting it out of the car and running is a lot of that is driven by the thalamus, which is telling us to get there. But let's just say you're kind of running to the building and all of a sudden it stops. So at some point your body has to say, oh my gosh, it's time to slow down. I've got to slow down and get to the walk. Well, the substantia nigra is the part that kind of tells also the thalamus to say, oh, let's kind of slow it down. So you can kind of hopefully see that this is a dual action that occurs, and all of this really depends upon the use of dopamine. So let me go a little bit further and talk a little bit about some of the findings that you're going to see. Usually, and again, we know that this can occur in any age, but it's typically more common middle age to above, and even more common after the age of 60. And so it comes down to kind of three main categories, although I have a mnemonic called a trap. And so the big things are you have a tremor, and we call this the pill rolling kind of tremor. So it's almost as if you take your thumb, and if they call it, if you had a pill and you were rolling it around in the palm and the fingers, that would be pill rolling. It's a very common observation that you can find in somebody who has Parkinson's. And again, they use their thumb, they use their fingers, and it kind of seems like as if there's something that they keep rolling around in their hand. And the tremor is going to happen most often at rest. And that this tremor, so if you ask the person to do something, or I'm sorry, not to ask them to do something, but if they're in a more stressful condition, then, and like let's just say if they're obviously that people are watching them, that this will actually come out more. So we have this component of tremors, and also we have the R stands for rigidity. So the muscles are stiff. We had seen about the lead pipe. So the lead pipe that the neurologist was actually showing us. Think of a lead pipe as increased muscle tone. So increased muscle tone. So if you do, and sometimes you have to do some extra movements to try to pull it out, but usually we can pull this out upon passive movement. So if you are actually kind of not having the person do it, but you're actually moving that arm, you can just feel that it doesn't seem to be very smooth, but it feels very like they call it the lead pipe. And then the other thing that can have as part of muscle rigidity is the cogwheeling. So as we saw that the neurologist in the movie was able to pull that out by moving the opposite hand up and down, and cogwheel rigidity seems to be more of a jerky but stiff type of motion that occurs in people with Parkinson's. And the third part, the A, which can also be B, but akinesia or bradykinesia. So again, you'll see this kind of slow blank expression. They have difficulty in initiating movement, and I'm also going to throw freezing into that, and that's the kind of, and freezing is kind of the situation where you can come across somebody who has this, and if somebody has Parkinson's, if you ask them to walk, they kind of hesitate initially. So it's like that first step, it's almost like they're walking, their feet are glued to the floor, and they have a hard time in starting that first step. Once they get going, that kind of disappears, but that's something that we can see. The other kind of things is, and that's where, I kind of have in this slide, difficulty in initiating movement. So that's what is something that you will see as sometimes referred to as freezing. They may have difficulty in swallowing, so food as it progresses can be more difficult, and dietary changes are often needed to be made. And then the other thing has to do with postural instability. So in terms of the postural instability, so people who have Parkinson's may have some difficulty in being, they're just not that stable on their feet. I'm not saying that they're going to fall. They're not going to be like the person who has cerebellar ataxia, where you feel that they may end up falling if you do one thing, but they're not as steady on their feet as normal. The other couple things I wanted to talk about, so we talked about freezing, is micrographia. And this has to do with shrinkage of their actual handwriting. So if you were to see somebody who has Parkinson's and ask them to write, the height of their words actually over time becomes much more smaller. Poverty of movement, again, and that's kind of an umbrella term. We saw that with the woman, in fact, that again, there wasn't a big arm swing. There doesn't seem to be a whole lot of movement that occurs. It's very slow. It's very purposeful, but I almost call it not a lot of expression in their movement and their speech. So oftentimes with Parkinson's disease, their speech will become softer, possibly slurred, and this has to do with their muscle control. So we did see this video regarding the Parkinson's person, so I'm not going to necessarily go into that again. So let's talk a little bit about sensory tactic gait. Both of these videos are relatively short, and I think the big thing, as we talked a little bit about before, if you lose your posterior columns, you can have this wide base gait, and also you will tend to have a Romberg sign. These are both short. The key thing to keep in mind with these is their wide base. Unfortunately, you can't see the person's face on this, but many times people who do have sensory tactic gait will want to kind of look at the floor to sort of help them with their balance. The chorea gait is what we call a hyperkinetic gait, and this is just so doggone unique, and I almost think of it as very, very kind of bizarre. So they're using all these additional movements, And the gait is, he does a really good job of showing you what the actual gait appears like. So when you take a look at this gait, it's kind of bizarre in that the person is moving and seemingly jerking in all different directions. The word chorea actually, if nobody knows, means, I think it comes from a Greek word that means to dance. And so people who do have chorea, either movements or choreiform gait, they're not able to sustain a normal posture, and even though they may be cognizant, they just cannot stop all these movements. So you cannot talk about the chorea gait or chorea in general without talking about a disease called Huntington's, which is a progressive neurological disorder, and this is oftentimes a hereditary disease process. I believe that there is a video amongst here which shows the neurologist actually interviewing somebody with chorea. So chorea in and of itself, or choreiform movements, though we can see it in diseases, but we can also see it in other things as well. People who get rheumatic fever, and we don't really see this much in the United States, but if you go to some third world countries and they're not treated for rheumatic fever, that there is a small percentage of patients who get it who will end up getting what we call Sydenham's chorea. So they will get this as a complication of that. In addition, you can get what we call chorea gravidarum, which is a rare sort of chorea that is a complication of pregnancy, and we can never forget about drugs. We have seen these in the past, and again, some of the first generation antipsychotics such as Haldol have been linked to this. Also levodopa, which is used for Parkinson's disease. Some atypical or second generation anticonvulsants have been associated with this, as are some important drugs which we still, though rarely use. Some things like Reglan, which had been used for GI disorders, as well as Compasine, which was used for anti-nausea medication. So we can see it in other conditions as well. So let's talk a little bit about movements. And choreiform movements are somewhat interesting in that they, as I said before, they tend to be quite bizarre in their movement. So particularly pay attention to, I think it's the second video, where you can actually see somebody with Huntington's chorea, and you can see that there's quite a lot of movement that goes on with that. Another type of movement that we will see is called athetosis. Athetosis is a type of chorea, but it's actually sort of a slower form of it. So sometimes you'll see people who have this, and their fingers and their hands almost seem to be twisted, and they may use type of a writhing or squirming, or people may call it snake-like twisting movements, and if you're going to see it, you're most commonly going to see these in the hands and or the feet. So there's a little video regarding that. Fasciculations. Going back to athetosis. So, where do you see athetosis? So, yeah, you can see this in people who may have Wilson's disease or abnormal accumulation of copper, strokes, cerebral palsies is probably one of the more common ones we see. In even destruction of the basal ganglia, we can see this as well. So going on to fasciculations, fasciculations are really a spontaneous depolarization of a lower motor neuron. And so it's a contraction that's happening in a single muscle group. I don't know if you have all probably experienced fasciculations. They're oftentimes benign. I can remember when I was a kid and I'm kind of looking at this eye, and this is a really weird drawing, but I can remember when my eye would just twitch as when I was like 7, 8, 9, 10 years old. And it was bizarre, but it would just do that and then it would stop. Or think about this. If let's just say you run or you're working out, and then you can kind of feel an area of your body that just might start twitching. Again, these are involuntary, and then they oftentimes will stop, but we can also see these with other components as well. So let me just give you an example. So we can see fasciculations in people who may be treated for asthma, and we give them Preventol, or we give them Ventolin, or we can sometimes see them with stimulants. So if people get medications for ADHD, they may experience fasciculations as well. Obviously, you can see them certainly with deficiency. So again, with dehydration or magnesium deficiency, we can actually see fasciculations as well. Tics is a sudden, repetitive, non-rhythmic motor movement that involves very discrete muscle groups. Now, whoa, my voice went really high. Now, tics can be something that you can observe, or you may not be able to see them very clearly at all. And tics can actually be both motor and vocal, and so some of the common types of tics that can occur could be things like an eye twitching or eye blinking. Sometimes people who have tics will do throat clearing quite frequently, so they'll just kind of clear their throat, and that may actually, you may not know that, but that might actually be a tic. Sometimes things you won't observe might be something like the toes might curl in, or the other kind of tics that can be seen can be phonetic. So these are the ones that tend to be somewhat even bizarre. So people with tics may actually be talking to you, or they may not be talking at all, and then all of a sudden some words just come out. And sometimes the words can be quite interesting. And by interesting, I mean that many times people with these tics can actually throw out words that are quite inappropriate. So just understand that tics can happen, and especially you have to be a little bit cognizant of the people who actually throw out obscenities with some of their vocal or phonetic tics. Myoclonus is basically just they're sudden, they're brief, they're involuntary jerking. So we may see these in an arm, in a leg, or an arm and a leg. And again, it's more of a combined kind of effect, so it seems to be larger when they're affecting the arms or the legs. So it's not just like an eye that's twitching, but it's a whole movement of a larger extremity. Where do we see these? These can happen in a lot of things. So seizure disorder, I think, is one of the biggest portion, multiple sclerosis and Parkinson's. So we can see these in a variety of various conditions where you will end up seeing these. Intention tremors. So intention tremors these are what we call low frequency, usually less than 5 hertz. And so they're broad, they're coarse, and that the intention tremors, the amplitude. So if somebody has an intention tremor, and you can see this on the video that accompanies this, that as the person who has intention tremor gets closer to what they're supposed to be doing. So in the video you'll see that they're trying to have him touch touch space and then touch his nose. But as he gets closer to the thing that he has to touch, which is his nose, the tremor becomes much more visible, and oftentimes the person will, the tremor is usually perpendicular to the movement in which they're trying to do. And so oftentimes with attention tremors, they don't actually hit their target, meaning that they may overshoot it or go past it or not make it to it. And so we think about this as being oftentimes a cerebellar tremor. The big thing to keep in mind is making sure that you keep this differentiated from both the Parkinson's, which is a resting tremor, and then also the essential tremor, which is very common. And just to make you a little bit knowledgeable about an essential tremor, this is involuntary. Again, this tends to occur more often in family groups. There's a strong family history associated, and when you see the tremor, most oftenly when they're doing very purposeful movement. So let's just say somebody who has an essential tremor and they want to button their shirt. As they're trying to button that shirt, that tremor will come out. And you can also see that in an essential tremor, that if the patient is trying to do something in a fixed position, so simplest, stand up and hold your arms out, that you will, against gravity, that you will see this tremor exhibited. So this is kind of the video or a slide showing some differentiation between a Parkinson's tremor and an essential tremor. And I think this is pretty good in showing you some of the things that help differentiate. And so essential tremor is probably one of the most common things that you are going to come across. And as you can see on the slide, one of the most important things that help you is looking at that alcohol, because people who have essential tremor will tell you that if they drink alcohol, the tremor actually gets better. So a little bit into aphasias. And aphasias, as I said the other day, that aphasias are a very broad term, and there are very different kinds of aphasias that one can encounter. But I think that these two are some of the most interesting aphasias, and you'll likely to encounter people who have that. So it's important to understand the difference in them. So somebody who has Wernicke's aphasia is what we group as being receptive, meaning that they cannot they cannot comprehend, even though it seems like they seem to know what they're talking about, they really don't. Because patients who actually recover from Wernicke's aphasia and know that while they were aphasic, they often found the speech of others unintelligible, and despite the fact that they seem to be cognizant of the fact that they are speaking, they could never really stop themselves nor really understand their own words. So this is really a receptive aphasia. So the thing about this is they will speak, and they will have sometimes normal grammar and the rate maybe, but what comes out of their voice and what comes out of them is so interesting. And I have a very good film that kind of displays that. So we have to actually compare this to Broca's aphasia. Broca's aphasia has to do with affecting the frontal lobe, versus Wernicke's is affecting the temporal lobe. So two totally different areas. So people who have global aphasias, and most often time these people have had some sort of insult to the brain, mainly strokes and things like that, but it could be from other things as well, from tumors and infections. But Broca's aphasia. So somebody's got a Broca's aphasia, they understand absolutely what is being said to them. Where their trouble comes is their ability to express it. So they have difficulty in their speech. They will tend to drop words, or they will speak just a couple of words. They know what they want to say, but it just can't get out. So I do have some film that does show both of these. So going on, we're going to talk a little bit about levels of consciousness. And I think that understanding kind of the levels of consciousness becomes pretty important, because you're going to be able to, when you're seeing people, you might want to talk about this person is lethargic, or they're stuporous, or obtunded. So what does that all mean? So let me kind of give you, we know that alert and oriented la 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 is a totally normal person. So who is lethargic? So you're going to, in order to be able to try to elicit this, probably one of the first things you're going to do is just kind of look at them, observe them, and just talk to them. So I think of a lethargic person, and you can sort of see that the response oftentimes is drowsy. They may open their eyes and then they'll fall asleep. So we find these in people who are sick. I can even see it in kids who are sick. So, you've got a 4-year-old who's got a temperature of 104. So they're sleepy, they look drowsy, they'll respond to you, but they want to kind of go back to sleep. So that's a lethargic person. An obtunded person is the person who probably is not going to respond to you very well with voice commands. So they're the person who you're going to they're going to open your eyes, you're going to shake them, open your eyes, so you're going to say something, maybe not full sentences, they may seem confused. If I were to give you an example of this, I'm going to go back to, oh my gosh, that drunk person who came over to your house and fell asleep on your couch, and they're passed out on the couch. You kind of have to shake to awake them. They look at you. They say, "Hey, how did I get here?" And then they kind of go back to sleep. So that's kind of where I think an obtunded person would be. The stuporous person is more than likely going to be somebody you're going to encounter in the hospital, because this is a person who you need painful stimuli to get anything out. And so you're not going to shake them and they're going to be arousable, but you got to give them pain. And then when the stimulus kind of stops, that's going to, then that they're going to be totally unresponsible. So I think about this as somebody who may be in the hospital, has had a major head injury, and maybe not be, they may be intubated, they may not be intubated, but again, these people, their consciousness is very, very subdued. And coma. So coma, you could do whatever you want to them, but they're not going to respond to you at all. So, what is coma? Oftentimes I'll hear people and they say the person, they're in a coma, like as if a coma is one word, but a coma is not the word, it's coma. So, let's just kind of again review what the definition is. So, really, this is unarousable, unresponsible state. And typically, when somebody is in a coma, their higher cortical functioning is not working. So the things that are working are really at the level of the brain stem. So very infantile type of consciousness that is involved here. and it's really not pleasant to see. The Glasgow Coma Scale is something that is used both in mainly in trauma or neurological, neurosurgical conditions in which this was developed by a person. I don't think his name is Glasgow, but I believe that it was developed from a person at Glasgow University in Scotland, if I'm not mistaken. And this is a scoring ability to identify to what level of coma might somebody be in, meaning what is their actual level of consciousness health. And this is a scale that is used, and it's based upon these three main categories, such as eye-opening, motor response, and verbal response. So you can kind of see that you and I are going to have a score of totally normal, which would be 4 for eye-opening spontaneously. You can follow commands. If somebody asks you to pick up a piece of paper, you could do that, and that a person may be oriented to person, place, and time. But we typically see this in a scale that goes from 0, well, really 3 is going to be the minimum, to 15. 15 is normal. And most oftentimes we will consider people to be in a coma once they have reached anything less than 8. So that would be somebody who is considered to be in a coma. And oftentimes, where do we see this? I can tell you that in people who may have, let's just say somebody has had major neural surgery, they've had a tumor removed, they're under sedation, and or they've had a major insult. This will be something the nurses will continue to score, and on the previous slide you actually saw a typical scale. So they may follow them. They may ask the person to please record their GCS scores every hour, and again, this is kind of a scoring scale that is being followed. So again, you can see this on the video of how they do it. I'm not going to give you a question on the test of, oh, this person has a GSE score of 10. What will that be? I think it's interesting to know about, but I don't think you need to, feel that you need to try to learn every single point on that scale. So posturing, these are very important. So I'm going to talk first about hemiplegia. So hemiplegia, again, this is somebody who may have had a stroke or some sort of insult in which early on you're going to possibly see somebody, what we call having paralysis, or it could be paresis too, but plegia is paralysis of one side, one half side. So the right upper arm and the right leg, or the right arm and the right leg on a person may be affected, or a left arm and a left leg may be affected. And so what typically can happen in somebody who's got somebody who may have hemiplegia is where early they may have a flaccid one side, so the arm may be held, doesn't seem to be working, and the distal extremity tends to have external rotation of the hip. In addition, you may see some findings that will also be found on the face. So hemiplegia, pretty simple. So let's also talk about decorticate and dyscerebrate. So decorticate and decerebrate are two important components, and they kind of give us an idea how severe a brain injury may be. So I will tell you that decorticate is corticate is actually the better of the two. Oh my gosh, as I'm looking at this, I'm saying, they have these actually wrong, because decorticate is actually the decerebrate picture. So decorticate is the type of condition in which the arms are flexed very tight, and adduction occurs, and you will see internal rotation of the hips and plantar flexion of the feet. Decerebrate is bad, and decerebrate is basically the worst possible scenario, because this truly means that there has been significant lower pons, brainstem, insult. And typically, if you see somebody who is in a decerebrate position, that usually signals that that person will not survive. So the decerebrate picture is actually the first picture, so they have that wrong in the book. So decerebrate is the first picture, in which you can sort of see that there's a adducted, pronated, internally rotated component of their arms, and their feet are oftentimes plantar flex. So decerebrate is really kind of the worst component that you will find. And actually the film is going to be able to show you some of that. So what you see on the picture of this lady right now, so she is going from a decorticate into a decerebrate posturing, and it shows it extremely well. Meningitis. Oh, for meningitis. So meningitis is a horrific condition, inflammation of the meninges. So the meninges, as you can kind of see from that from that picture that's blown up a little bit. Brain, cerebral spinal fluid, and then we have the meninges. So if you get, for some reason, bacteria into the cerebral spinal fluid, that is going to cause inflammation of the meninges. What causes meningitis? Lots of things. The worst ones, again, I guess you can also, worst ones that we think in general, at least the scariest ones that come to mind, are the bacterial ones, but the fungi ones can be very dangerous, as could be the viral ones. But bacteria ones are the ones that, geez, this is the ones you don't want to miss in a small child. So keep that in mind. So what happens with somebody who has meningitis? Number one, they typically will complain of fevers, headaches, stiff necks, nausea, vomiting, and they may have a possible meningococcal. They may end up getting a rash that may be associated with it, confusion, sensitivity with light, and photophobia. So we talk a little bit about some of the signs that you may be able to pick up with somebody who may have meningitis, and these are not necessarily the most specific or sensitive, but it's something that could possibly be found. The first one is called the Brzezinski the Brzezinski sign. So basically, if you have a small child, as noted here, and you're worried about whether or not they might have meningitis, if you flex the neck forward and the knees and the hips flex at the same time, and again, in somebody who has meningitis, this is a type of maneuver that's going to irritate the meninges. So a Brzezinski sign would be flexion of the neck with both the knees and the hips flexing at the same time. Koenig sign is a sign, and again, I kind of associate this with the K, knee, Koenig's. Having the patient raise their leg, so the child or whomever is laying down, and you raise the leg with the knee flexed. So the knee initially is going to have a little bit of flexion to it, and then you try to extend that leg or knee. And somebody who has a positive Koenig sign does not want to, or it is painful, or there's pain in the hamstring when you try to extend that knee, which had been held in a somewhat flexed position. So that's a positive Koenig sign. Seizures are very cool, and I think this is a really good chart which helps try to differentiate partial generalized seizures. So again, partial meaning that it occurs in one part of only in a part of a brain, where generalized seizures, this tends to be a more global type of involvement. And this actually is nice in helping you to identify which ones are which, and keeping in mind that partial seizures, such as a simple partial seizure or a complex partial seizure, that their awareness, though may be altered, they are not, even though their awareness may be altered, they're not totally unconscious for this. So in generalized seizures, their awareness is always impaired. Okay. So I'm going to take you through a few of these, a couple findings with seizures in general. So some of the symptoms that can occur with the seizure is things such as they may identify with a certain smell, or they may have halos, or they might have abnormal sensations. So sometimes people who do have seizures know that they're about to have seizures because they can kind of have this aura that something's about to happen. And so they can actually, I actually had a friend who had, this was back when I was in college, who had seizure disorder, and she always had auras. She knew exactly when her seizure was occur. She would hear a type of a sound, like a bell type of a sound, that would be going on in the back of her head, and then she would go into a complete generalized seizure. So some people may have aura, some people may just stare. I think the absence ones are really kind of interesting. It's almost like they're staring off into space. They may lose complete consciousness. They may actually just have jerking of various arms or part of an extremity. They might do some very unusual habits, such as rubbing their hand, or even pill rolling kind of activity, or they might just do several unusual things, such as they might just pick at their clothes. You'll see people that'll pick at buttons or just pick at their clothes. In some seizures, they will lose control of their bowel or bladder, and in some seizures, you're going to see that they're going to have a post-ictal state. So it's a state of drowsiness, or perhaps they might just be lethargic for a period of time, might be a little confused, and normally this can, for people who have post-ictal states, it can last for several minutes or even up to 30 minutes. So we know that the upper motor neuron and lower motor neuron are important in helping to relay messages from your brain to your spinal cord to your muscles. And we know that the upper motor neuron is going to connect the brain to the spinal cord, and that the lower motor neurons are the things that connect the spinal cord to the muscle. So this is, I think, a pretty basic review of upper and motor neuron. The key comes is, how do you know whether or not somebody is having upper motor neuron or lower motor neuron involvement? And that's kind of taking a look at the patient and trying to see what's happening. So we can look at atrophy, and atrophy in people who may have upper motor neuron can exist, but it's often, if it does exist, it's because that they're not using that part of the body. So it's not something that we would expect to necessarily see, versus somebody who's got a lower motor neuron. So let me give you an example. People who may have cerebral palsy might have an upper motor neuron insult, and people who perhaps might have a stroke, or they may have not so much a stroke as, they can have a stroke, but the insult has affected the whole lower motor neuron component. So in people who have lower motor neuron disease or insult, they will have significant muscle atrophy. These are the kind of people where you will look at them and you're like, they have no muscles on their lower legs. And people who have fasciculations, again, fasciculations are obviously some smaller contractions of various muscle groups will be present, but it may not be present and not present in somebody who's got upper motor neuron. People who have lower motor neuron tend to get hyporeflexia. So I'll give you an example. So one type of a lower motor neuron insult could be that somebody might have a disrupted nerve root. So they may have loss of the patellar reflex. That could be an example of a lower motor neuron insult, and so they will have hyporeflexic. Somebody who has cerebral palsy might have hyperreflexy. People who have lower motor neuron may have will have what we call normal Babinski reflexes, versus somebody who have an upper motor neuron will have that upgoing toe in which the Babinski will be present. And so I think one of the other kind of key things to differentiated upper and lower motor neuron aspects has to do with the spasticity versus flaccid. So people who may have cerebral palsy, upper motor neuron, they may get spastic components in which their muscles are continuously being contracted, so they're always being fired, and the problem is that they cannot complete that loop from going from the brain to the spinal cord to the muscles, and so that loop is never being never being continued all the way from the brain all the way to the muscles to the final muscle group. And so it's almost as if the nerve itself is in constant contraction. So spastic paralysis is something that is very specific to upper motor neurons. You'll see these in people who oftentimes will have MS, cerebral palsy, people who even have ALS, in ALS you can have both upper and lower. I actually have a nephew who has a progressive neurological disease, and he is always having spastic paralysis. So, and sometimes this paralysis can be due to a very small situation. So almost anything can cause spasticity, where it seems like that muscle seems so stiff and it seems like it's constantly being contracted. So people who do have say MS and they get a kidney infection or a UTI, they will, if you take a look at them, they may have their legs which seem to be so stiff, and it's constantly kind of can be actually moving. So that's a spastic response that can occur. So upper motor neuron and lower motor neuron, I think this is a real big key, and this helps us in determining whether or not somebody who comes in may have had a stroke or a peripheral nerve that has affected the seventh nerve, and this is kind of a key thing to keep in mind. And I think that this is really important because we are very keen to diagnosing somebody's with Bell's palsy, which is a peripheral paralysis of the seventh nerve. So you remember all the things that we test for the seventh nerve: raise your eyebrows, puff out your cheeks, all those kind of things. So if somebody comes in and they seem to have some sort of paralysis that you think that is involving the seventh nerve, make sure that this is not a stroke, because that's important. Because I think that if you look at this picture, that you can see that say somebody has so let's look at what the upper motor neuron what is the division, or how do things interact from the upper motor neuron to the lower motor neuron. So you can see that up in the brain, you actually have inputs from the right side of the brain and the left side of the brain, which then go to the facial nerve and are important in control of many of the movements of the entire face. So somebody, as diagrammed here, who has, let's just say they've had a stroke up in their cortical hemisphere, in this area, which has affected the output from the muscle groups in the cortical region, down through the cranial nerve nucleus and down through their face. So somebody who actually has a stroke that's just affected their cortical region is only going to be affected in the lower portion of one side of their face, as demonstrated here. So you can sort of see that somebody who's had a stroke, and as we follow this down and we follow these outputs down from the brain, you can sort of see that from the brain, one of these outputs goes into each of the nuclei of the seventh cranial nerve, one on the right and one on the left. But that the cranial nerve is also receiving input from the opposite side. So that if somebody has a lesion way up in their brain, that because of the dual intervention of the face, only one half of one side of the face is going to be affected. So as in this picture here, the only thing that are going to be paralyzed or paresis from a stroke is typically going to be one half, so the lower aspect of one side of the face, as demonstrated here in purple. Compare that to somebody who has, again, a virus, something that has affected the lower motor neuron. So again, this virus is affecting the nerves from the of cranial nerve 7 at lower down in the brain. This person, so once it, you can sort of see, because it is lower, it is going to affect one half of the side, because nothing from the upper aspect is going to be able to reach that lower aspect. So somebody who's got a peripheral or lower motor neuron lesion is going to have symptoms and signs that are going to affect one half of one side of their face, as demonstrated here in the kind of orangey shading. So love this video. This is one of my favorite videos of all time, because this guy, and again, he jokes about it. He's making light of his situation. I get it. Some people don't, but he actually recovered. But I get his humor. So some of the things that people who tend to have with some of the lower motor neuron lesions, they get decreased tearing, and it's not because of the fact that they're they're not making tears. It has to do with weakness of the orbicularis oculi muscle, but they may also complain, you'll see that they'll complain of not being able to eat very good on that side. They may complain of some blurred vision. The upper eyelid is not going to close well. They may complain of some pain in the ear, or even a hyperacuity to sound. So this is an interesting thing, an important concept to really try to make sure you understand.